Hello, hello, and welcome everyone. I'm just getting everything set up. I am here and we will get streaming here in just a moment. See here, I clicked out of the wrong thing here, so just give me just getting everything going. We've got to stream a little bit here. How's everyone doing today? Hope you're all well. If you have any questions, go ahead and you can put them in the chat. And it looks like, let me see here. See if we're gonna get this to go. Oh, it's cold. I'm in Colorado and we finally got some snow. I don't know if you've heard or where you're located, but Colorado, we typically get, a lot of snow. We're pretty well known for our skiing, and that's something that my kids and I love to do. And unfortunately, this year it's just been so dry. We skied a little bit over the holiday break, and let me tell you, like a lot of people, I think, canceled their trips. It was just not very busy, and the snow is not great. So, but we finally got some snow, and I think there's probably like what, 4 inches outside of my house right now, but it's cold. I'm not used to it. Okay, we are going to talk about the female reproductive, and I want to keep this really interactive. I have a lot of different slides here for you. I also put together some questions. So if you prefer to do questions, just let me know, and I'm happy to do that. You can put that in the chat section. Um, and if you want me just to do a review, we can go over a review, okay? As we're moving through this, I welcome questions, I welcome engagement. And this is an area of passion of mine. I worked as a labor and delivery nurse for about my last years I was more per diem, but close to 10 years working in Seattle in a pretty busy like urban hospital where we had a lot of different births. And so I did a lot around pregnancy, antepartum, labor and delivery, and then also postpartum during my nursing experience. And then I went back and I got my F&P license, worked in primary care, and then I also work on what here in Denver, we have a mobile health unit. And so I do that a little bit. And so we go all over. We do lots of different things in our mobile units. We have several that go around the city. I personally work on the women's health one. Um, and we do a lot of cancer screening. So we'll do pap smears. We also are able to offer mammograms on our unit, which is super awesome. It's this big kind of RV. I feel like it's kind of like working in an airplane because everything's a smaller size and you have to like be able to kind of get around and to be able to do a pelvic exam in an RV. I liken it to getting your pap smear when you're on a camping trip. Like, how more natural is that? Just a joke. But yeah, so it's pretty fun. So I have a lot of experience in the female reproductive world. I recently did my menopause certification and work with a lot of women around menopause hormone therapy, just to make people feel their best and hopefully stop minimizing symptoms and so forth. So that's kind of my area of expertise. So I love talking on this subject, but I really want to design it to what it is that my audience and students are requesting and need. So if there's anything you want me to slow down, review, just let me know. Okay. Just before we get started, a few quick things that we have. Kiva and I, we're doing these webinars. We're constantly trying to bring you guys good content. We do have a board's power prep coming up on January 21st. That's a 1 day live review. So if you're getting ready for your boards exam, this is an excellent, quick, down dirty review of everything that you need to know. I find that it's a really great way to understand what is it the areas that you don't quite know and you need to study a little bit more on your own independently. You can scan this QR code to register. You can also email us if you have any questions about that. Um, As always, doing lots and lots of questions for your board prep is our recommendation. 25 to 50 questions every single day is going to get you there. And then at least one practice exam. I like to do them weekly and then use your scores and the areas of weakness to really guide what you're going to work on the following week. And so those are my recommendations as you're moving forward. Um, and if you have any questions about any of that, let us know. We also do private tutoring. I love working one-on-one with students. It's so great. We get to really focus on what it is that you want. Mostly we do a lot of questions together. We do review content and we go over how do we answer these questions the best. And then I can kind of understand where is your thought process and maybe where are things not going quite right. How can we kind of change where we make these errors to best help you pass your boards exams. So lots of different cool things that we're offering. 2026 is going to be a great year. Really excited about everything that's to come this year. We're working on a lot of different projects. So we're excited to share those with you guys. Yes. And I got these new glasses. My kids, I don't know if you guys are into the language that these younger generations, maybe some of you are in the younger generations, but my kids told me I looked chopped, so that was very nice. I they said that I looked a lot older. So that's trying out these new glasses today. But I can see in like 3D, which is so good. I can happy to get a new prescription and be able to really see. So maybe I do look a little chopped, but that's for the Gen Z population out there. Fun. Okay, let's delve into a little bit around the female reproductive system. Here are our learning objectives. It's just really easy. This is a 30-minute webinar. We don't get to go real deep, but let's just do a quick brief review, some of these common conditions and what we do about them. Okay, so just a brief anatomy review. Okay, women have a uterus. That's um, where an egg would implant and then grow. We have ovaries, that's where the eggs are created, and then they go through the fallopian tubes down. And insemination typically happens during that fallopian tube transit. And so, what we can have, and something to always rule out, is a pregnancy that actually occurs in that fallopian tube. That is considered an ectopic outside of the uterus, not where it's supposed to be, a pregnancy happening in an area. So, imagine you have all these cells dividing here in that fallopian tube. That is a dangerous situation. Then down here at the bottom of our uterus, we have what's considered our cervix. That cervix's job is really to hold tight, keep everything in there during a pregnancy, and then it opens, dilates. It actually gets smaller. So that's your effacement, and then your dilation is the opening of that cervix. So we get 100% effaced, where it's a very thin cervix. It's no longer that thick little knob there, but it thins out and then it opens up. And so effacement is the thinning, and dilation is the opening of the cervix. It needs to be 100% effaced and 10 centimeters dilated for a baby to pass through. We also know that cervical cancer is a common concern here, and so we do what's considered a pap smear on a regular basis to prevent or to find any abnormal cells before they become cancerous and treat those cells, right? So we do our pap smears. We're looking for HPV specifically because we know the HPV virus, certain strains of that virus cause cervical cancer. And so that's really what we're considering here. We have our vagina, which is just the birth canal or the passageway. It's filled with a lot of rugae, and we know that the vagina can stretch, allowing passage. And that is that. And then we have our vulva, which is our external part. We have our clitoris, we have our urethra, and then we have our rectum. But the vulva is the external part. We have our labia minora and labia majora, of which we consider to have different functions. A lot of people will liken the clitoris to kind of the glands around the penis. It has a lot of nerve endings there. And so just understanding the terminology and making sure that we're using the correct terminology. The external part is not the vagina. The vagina is the canal, and the external part is what we call the vulva. Okay, and we know that we go through we have our reproductive life cycle, right? And that is any starts anywhere between the ages of 10 and 14, really. And that is when we start being able to conceive. And this is when we start having conversations around contraception use, because the moment that we enter our reproductive phase of life, that is when we are at we can become pregnant if we want to or not. That's a conversation with each individual, right? Um, when we think about our menstrual cycle, we think about these different phases. So that uterus is going to, in response to estrogen, is going to grow nice and thick. And that is during that part of the follicular phase where we're seeing that uterine lining getting nice and thick in anticipation of ovulation. So when that egg is now released, if in fact we were to have intercourse or some sort of fertilization were to occur, whatever way, shape, or form that happens, that egg then implants into that nice thickened bed of tissue from the estrogen that grows that. Progesterone job is to come in and maintain that nice thickened line until implantation occurs. If implantation does not occur, progesterone levels fall because of the lack of the egg, those progesterone levels fall, and now our uterine lining, we enter the luteal phase, and then those progesterone levels are falling, the estrogen levels are falling. And when those levels come down far enough, we shed whatever we grew if fertilization did not and implantation did not occur. Okay. And then we complete that cycle. Most women live on about a 21 to 30-day cycle, the average being about 28 days. So it doesn't follow a calendar. And so a lot of patients will ask me, well, I don't know why, but I don't get my period. I thought I was getting my period on the 5th of every month, but it's like the 5th, and then it's the 3rd, and then it's the 28th. And it's going to keep changing because it's a 28-day cycle. And most of our months are 30 to 31 days, right? And so I have that conversation. Now, we're going to have variability around that menstrual cycle, and that's okay. But if we're not using any sort of hormones, we want to make sure that we're having a menstrual cycle at least every 90 days. So we're not continuing to grow that uterine lining. Because when we grow, and we have more and more thickening, and we're not getting that shedding of that tissue, what increases as a risk factor is dysplasia, or what we consider cancer, hyperplasia. And we can have some cellular changes that would be abnormal in that uterine lining. So we want to make sure that we're shedding that lining at least every 90 days, unless we are somehow hormonally suppressing the growth of the tissue. So when we use things like contraception, oftentimes what we're doing, and why women ask us, what is this story about not actually shedding my lining? I'm not getting my period, and that scares me. Why am I not getting my period? Well, because we're suppressing the growth of that tissue with the oral contraceptive, or the IUD, or the Nexplanon. Anything that has a little bit of hormone, we're actually just not letting that uterine lining grow too thick. And it's completely safe. We know that the moment that we stop it, it may take some time, or it might not. So I always tell people, if you're stopping a birth control, expect that you could get pregnant if you're having sex with a cisgendered male. You could get pregnant right away, and it might take a little bit of time to reestablish this menstrual cycle and get all of these hormones kind of out of your system. And every individual is different. So I just used one case. A good friend of mine had her IUD removed, and she had sex just previous to the IUD removal and ended up pregnant. Okay. So the sperm was still in her body. We now took out what she had, a copper IUD, took out that copper IUD, and she probably got pregnant from whatever sperm was still there. She happened to be ovulating at the right time. It was just a big mix of like, and a beautiful baby at the end, and everybody's happy. And but it just happened very quickly. So I'm gonna say it can happen fast, and it can take a long time. We can have dysregulation in our menstrual cycle, in our ovulation cycle, and we'll talk just a little bit about that. Okay, just real quick, brief review of contraception that we have. We have barrier methods, so condoms, right? Diaphragms, I haven't really seen them used very much, but we have male and female condoms. We have our hormonal methods, right? Those are something that has a hormone in them. Um, We have long acting, we have emergency contraception, we can do cycle tracking. So we know, looking back on that cycle, when is our most likely time to get pregnant? Anywhere between day 12 and day 16. That egg lives in our body for about 24 to 48 hours after it's been released. So if there's, and sperm lives in our body up to about 5 days, I think is on average. And so you think about if you had sex here and now you drop an egg, you could still get pregnant anywhere in this cycle, depending on when you're having sex or getting an insemination of sperm. So really important to educate people around what is happening with their body if they choose to use that cycling tracking. The caveat here is when we're ovulating, that's when that hormonal signaling to want to engage in sexual intercourse is going to be the strongest. And so that takes a lot of willpower for not using anything to say, well, you have to actually remain abstinent, or use a barrier method during those times in which your body might be sending those hormonal signals to engage in intercourse. So just a little bit of a like thing to think about when we're having that conversation. I have a lot of patients who maybe for different religious beliefs don't want to use any sort of birth control. And so we talk a lot about this. And what are some of the other signals that happen in our body that we're getting towards that ovulation phase? Um, we have changes in our like temperature, changes in what the mucus looks like that comes out of the vagina, stuff that we might see when we wipe and go to the bathroom or in our pan in our underwear. Those types of changes, it kind of becomes a stickier fluid as you think about it. It's trying to hold in some of that sperm in order to achieve what our bodies innately want to do, which is to get pregnant, right? That doesn't mean that we want to. How can we work with those things together? Okay, so that's a little bit about that cycle tracking. We also have sterilization. So in women, we can do what's called a tubal ligation. There's also some women have to get uteruses removed or ovaries and uterus removed, depending. In males, we do what's called a vasectomy, where we cut and we disconnect the vas deferens. That's that part that connects similarly to I think about the vas deferens and the fallopian tubes kind of in a similar way, right? It's bringing the egg or the sperm into the area where it's going to be released. So that's the same two places where they actually will do a sterilization thing. And I just heard, and I haven't done any research, but something around ovarian cancer and tubal ligation and feeling that I don't know the data yet, and I don't know if any of you have heard about this, but preventing a little bit of ovarian cancer through tubal ligation. So about 50% reduction is what I just read this morning. Again, I don't know. I didn't have a lot of time to dig in and see if this is really good science, but it came out. And so it's something to look into. It's a very interesting. Um, okay, let's talk really briefly. We have the male condoms, we have the female condoms, we have cervical caps, we have diaphragms. Um, Failure rate high, but this is how we present against STIs. Sorry, that should not say D. STIs, sexually transmitted infections. If we use them properly, about 87%. This is start to finish, okay? If we are and when we talk about contraception, I am talking about a cisgender female having intercourse with a cisgendered male or somebody who carries those abilities to conceive in this way. Okay, so we think that we need to use from start to finish, we need to be protected if, in fact, we don't want to conceive. All right. We have the sponge, which I don't know if any of you watched Seinfeld. It's kind of a good episode around the sponge. It has that spermicide. Spermicide does break down that barrier, or it kind of can cause a little bit of irritation in the vaginal canal. And whenever we cause irritation in the vaginal canal, we kind of open up our initial defense towards any sort of infection. So spermicides can increase the risk of a transmission of any sort of sexually transmitted infection because we're breaking down kind of the barrier. to our bodies a little bit through there. Okay. Hormonal contraceptions, we have a lot of different things here. We have pills, patches, rings, injectables. These also include those long-acting methods, IUDs, and implants that we have. For birth control pills, we have monophasic and biphasic and triphasic. This just allows for the exactly what it sounds like. So monophasic, we have 3 weeks of those active pills, that hormone, and then we have placebo. And the reason that we give these placebo pills is to not lose the habit of taking medicine. So I tell patients, go ahead, take them all. There are some birth controls where they're putting a little bit of iron during this week, and this is the week that you would have a period. And this is what we call a withdrawal bleed. Okay, it's not a true period, but when we stop the hormones, we have a withdrawal bleed. Biphasic here, halfway through, we have a slight increase in that progesterone about halfway through to make the bleed a little bit lighter. And then triphasic, these are going to be the most natural, kind of mimicking what happens in our body. Okay, we do see this kind of black box warning around Yaz, which is drospirenone with ethylene estradiol. Drospirenone is a synthetic progesterone, okay, so it does protect that uterine lining and something to think about. Some concerns around DVT, hyperkalemia. Here are our, absolute contraindications. We don't stop birth control in 35 years or older. We stop it if you are smoking in 35 years because of an increased risk of clotting, or if you have a clotting disorder, we're going to stop it. And here are some other indications. Migraines without aura, I use it oftentimes. If somebody is hypertensive, let's get that blood pressure under control. If they're very immobile, that would be a big warning sign, and know what a DVT looks like. Okay, we have our quick starts, which is just starting any day. We're going to use with anything, I always just recommend using a backup method, so a barrier method or abstinence for about 7 days after starting it. And then if you're consistent, we should see that things are working very, very well. But you want to take your birth control. I tell people set a timer, make sure you're taking it every single day. I find that, if you brush your teeth every morning, that's a wonderful time to take your birth control, as long as it's around the same time. Same time, especially important with mini pills. So these other pills that we're talking about back here are what's considered a combined oral contraceptive, COC, and that means it has estrogen or something similar to estrogen and something similar to progesterone in it. So maybe synthetic hormones, but that's what it's mimicking in our body. Progestin-only pill is what we use oftentimes, like for people who can't tolerate estrogen for some reason. I think of a little bit of endometriosis potentially. They can't, people who are lactating and want to continue breastfeeding, but they don't want to get pregnant. We can use something like a mini pill. The caveat with the mini pill is if you're just a few hours late, you increase your risk of pregnancy. Okay. These guys are very, very, very much need to be dosed at the same time every single day in order to prevent pregnancy. But the timing matters. Okay. So I find that most women who are on these are probably the ones that are lactating, and they don't want to have a baby, another baby quite yet. So just make sure that you're educating them that this pill needs to be taken at the same, like within an hour every single day. And if you miss a day, use a backup method for about 7 days to prevent pregnancy. The vaginal ring, it is a combined, it has both, and we can leave it in for 3 weeks, take it out for 7 days, have a bleed, but we can also leave it in a little bit longer. As you can see here, on the 10th week, we remove it and have a bleed. We are getting to the point where we're seeing that we can go longer and longer between bleeds, and that's okay if we are hormonally regulating it. I know that there are gynecologists out there that are not having any like breakthrough bleeds. Are or withdrawal bleeds. They are keeping somebody on a hormonal contraceptive consistently. And I try to do, I'm still at the 90-day. I try to have a withdrawal bleed every 90 days for people on some sort of hormonal thing. And then if I have somebody with something like a PCOS, I'm going to initiate a bleed every 90 days if their body doesn't create that on their own. We have the patch. This also is combined that estrogen and progesterone, similar things. And we'll keep a look on this. I have a feeling this black box warning is actually going away. If you're in the menopause world, we're seeing a lot of that go away on the patch itself. Okay, injectable Depo-Provera. This is progesterone only. This is a long acting. We give it every about 13 weeks. 12 to 13 weeks. So you have to come into the clinic to get this. I have a lot of teenagers that like this. We do consider a weight gain with the Depo-Provera. Very, very common. Okay. And then we have our long acting. Nexplanon is the implant. I like placing them. I actually have my little kit here to learn how to do it. You do need to be certified in order to place this and remove them. It's very, very easy. You can use that pop out method. I think it's kind of a fun, like, little thing to get certified in to kind of change up your day. The biggest reason people get these out is that irregular bleeding or spotting. Because this is a progesterone only and it's systemic, it doesn't seem to work as well as the IUD with the progesterone only IUD at kind of getting that complete atrophic state of the uterine lining and not having a little bit of that grow. So there's a little tiny bit of that growing that happens. And so you're going to shed, and you're going to shed kind of irregularly because those levels are just kind of irregular. I find that bleeding the first 3 months can be a little bit annoying. And then as it's getting closer to the time to replace it is when that bleeding comes back. I would say the number one reason I remove these is because of the spotting. And so that's what I tell people when I'm counseling them on their options. IUD is a bit more invasive in placement. I love IUDs. They're good for several years, depending on which one we choose. Um, it really depends on somebody's comfort level going through this. I try to provide a lot of reassurance. Like it is painful. There are folks that are using a little bit of local anesthesia to place that. I don't. I just haven't had that intense training in order to do a cervical block to place an IUD. And I actually find that it's a little bit it's painful. I don't want to minimize the pain that women experience, but I counsel on taking some ibuprofen before coming in and like a little heating pad while we're in the procedure. All of those things can help with pain management. I feel like they're probably going to look back on this and say, "Wow, we can do something else to help with the pain in the future." But this is a really, really great option. Making sure that you feel really confident in placing this and measuring, and so you're not at risk for actually perforating the uterine lining when you're placing it. So you can go too hard, too deep, and actually perforate through it and have this go on the outside of the uterus, which would be a medical emergency. So you want to make sure you have your training around this. It's a really, really great option, though. Risk of expulsion or migration is possible. Not too common, but we do hear about it. We hear, you've all heard about like a baby being born with IUD in their hands. It's possible, but the chances, this is probably one of the most effective forms of contraception apart from sterilization. Okay, Paragard. Now, this doesn't have any hormones in it, so a lot of people like that, but it can worsen your period. So I would say the pain, like if you have any dysmenorrhea or pain with your period, if you have a heavy period already and we put it in a copper IUD, we might make that worse. I would say the number one reason I take this one out is for anemia secondary to menorrhagia. So over too much bleeding during the menstrual cycle itself. But some people love them and they swear by them. So it's really individual. The copper just makes a hostile environment for sperm. And so sperm can't come, but you ovulate, you do all of those things. It's just there's no way for us to conceive when we have copper in there. Um, the metal itself, the copper. The other thing I want to say about the copper IUD is that we can use this in emergency contraception. We can place the Paragard if somebody has, had effects in the past like 48 to 72 hours. This could be an idea of emergency contraception. We also have these other medications. Oh, 5 days, sorry. Excuse me, within 5 days of unprotected sex. I haven't actually done that myself, but it's an option. Most people kind of prefer to go through one of these options. And now they're over the counter, so you can get Plan B without a prescription. So just making sure that teenagers, if you're working with adolescents, or anybody else, that they understand that they can get this. It's just a conversation during an annual wellness exam. Just, hey, just want to let you know that there's always this option if they're not wanting to use any sort of contraception. And yeah, these are those options here. Do you guys, we don't have a lot of time. Man, time passes so fast. Do you have any questions about stuff that we've talked about so far? Anything that you want me to go over really quickly in our last couple of minutes? You can feel free to put it in the chat. Um, but if not, I'm gonna jump over really quickly, and I'm gonna skip the pregnancy stuff. That's just not hit too much on our boards, but definitely review that. But let's talk really briefly about some common vaginal infections. So here are the most common things. We can have different STIs, but bacterial vaginosis and yeast infections are very, very common. And I want you to feel like you're really confident in diagnosing those. Um, we think of foul odor, itching, pain with urination, discharge, soreness. So like maybe we call it dyspareunia, periunia, when you're having intercourse and it's painful, or maybe you bleed. That can be a sign of something going on. Trichomonas is an STI, that yeast infection, and BV not considered that. Okay, so we diagnose vaginitis, bacterial vaginitis, just usually you can smell it. It's a bit of a fishy odor. We have that potassium hydroxide, or the KOH, that we can test on. You should see like kind of a grayish discharge with that fishy odor, maybe some discomfort. Some things that we think about when we're talking about vaginitis is we use, let me go back to this slide right here for BV. It's that metronidazole. So you can do oral, or you can do a vaginal application. Now, after that, I find that bacterial vaginosis creates what's called a biofilm, and it can be hard to penetrate. Have you ever heard of biofilms? It's kind of like this bacteria creates like really, really strong hold in that vault, and any change in pH. So during or after a menstrual cycle, a new sexual partner, or maybe different lubricant use, putting something new in the vagina, anything like that can disrupt that normal flora of the bacteria, of the good bacteria and bad bacteria in the vaginal vault, creating kind of an overgrowth of some of the BV, causing bacteria. It's I can't pronounce it, Giardialis or something like that, is the bacteria that actually overgrows in the vagina. So the education point that I have with people that have BV is, first off, I don't recommend douching or putting any sort of product in the vagina to create like a good smell, or to get this healthy pH balance, or anything like that. I had a gynecologist tell me the vagina is a self-cleaning oven. Just leave it alone, and it usually will take care of things. But the moment that we start introducing all of these different chemicals and smells and da 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 da, we can create a disruption. So we really like this overall balance between the good bacteria and the bad bacteria. Lactobacilli really help control things. Lactobacilli love estrogen. So we have an estrogen rich environment, we should be okay. That means that as we're going through menopause and transitioning into a lower estrogen environment, we're at increased risk of different types of infections in the vagina, because we now are losing our little lactobacilli, which really do love that estrogen, and flourish in an estrogen rich environment. Um, so what I tell people is, don't do anything, don't put any products in there. Um, and try to use, the same brand of condoms or lubricant, something that doesn't cause any change, that you can notice if you're doing something like that. And if you're having sex with a new partner, I do recommend always using a barrier method until you're in a stable relationship. And with BV specifically, if metronidazole is not effective or if we have a reoccurrence, then we start thinking about things like boric acid suppositories to really break down what that biofilm that can be created. Boric acid suppositories, you can read about it a little bit on Up to Date. But it's about a 28-day use a suppository, you place it at night, and it kind of does help treat that. So that's one option. I also really strongly encourage people not to use panty liners on a daily basis or really tight fitting clothing because it doesn't allow the breathing that's necessary, which can cause infections. Yeast infections, on the other hand, typically come after antibiotic use, really, really common. So if somebody's like, oh, all of a sudden I'm having this really intense itching in my private areas, and I was treated for, let's say, a sinus infection, or I was treated for an ear infection or pneumonia. Always, always, always think yeast infection. You can confirm it. And then we can do miconazole, which is that monostat, or you can do fluconazole or diflucan, which is an oral. You do one tablet, wait 3 days, repeat if symptoms are still present. Typically, it's gone in one treatment with an oral. But we can do whichever somebody prefers. UTIs, we treat for UTI, and then we get a yeast infection, really common. And so if you have a patient who tells you, hey, every time I get treated for a UTI, I develop a yeast infection. Can I get a prescription of that diflucan just to have on hand in case? I do give it. I give that prescription to have on hand in the event because you don't want to have to make them come back for a second visit. And if they constantly always get that yeast infection secondary to an antibiotic exposure, go ahead and do that. Again, it's a disruption in that normal flora and allowing that yeast to kind of take over. Um, because we've killed off the good bacteria. So just a few thoughts around those things to kind of take home. And then as we're hitting that menopause age, if you, depending on where you're at in your training and your interest areas, estrogen has really become a mainstream topic recently. You're probably learning way more about menopause in your programs, or I hope you are learning more about menopause in your programs, as this does affect 50% of the population at some point in their life. We're getting some new attention around this. So we actually changed the name from atrophic vaginitis over to that genitourinary symptoms of menopause, so GSM. And we can treat this. Most every single woman will have some degree of GSM. And using topical estrogen, vaginal estrogen, has nearly no contraindications and multiple benefits. So remember how we talked about that lactobacilli and that normal flora, that bacteria that love estrogen-rich environments, and that tissue really thrives in estrogen. When we go through menopause and now we're in a low estrogen state, what happens is that tissue becomes less elastic, less plump, less moist, like less lubricating. It kind of atrophies, it tightens, it doesn't stretch as well, and we also lose a lot of that good bacteria. So topical estrogen is something that I prescribe oftentimes. Being that I work in women's health that 1 day a week on the bus, this is something that's very, very commonly used. And it's always a conversation if somebody has a history of cancer, of an estrogen sensitive cancer, have a conversation with their oncologist around it before you're prescribing this. But I always encourage people, ask if I notice during an exam that there is a lot of irritation going on down there. I say, let's talk with your oncologist about potentially using just a little bit of topical estrogen cream to alleviate some of those symptoms to be able to maintain a healthy sexual life if that's something that you desire. Okay. Um, that about wraps it up. I really wanted to talk with you a little bit about PCOS, but it looks like we're going to have to save that for another day. Here's just a quick review. We use that Rotterdam criteria to diagnose. It's a bit of a diagnosis um, from investigation and having some of this stuff positive. We do want to treat to make to make sure we're having periods and we're not getting that overgrowth of that uterine lining in somebody with PCOS. But just familiarize yourself a little bit with some of those things. Okay. Any questions in the chat, any concerns, anything you wanted to go over? Again, we have that 1 day live review coming up on January 21st. I hope you all sign up and join us. We have so much fun. It's intense. It's a lot. And I find by the end of the day, you're just ready to be done. But it is a really good way to either just feel confident moving into that exam if it's time, or to help guide what it is where you want to study and put your focus as you're moving closer to that board exam date. Okay. It's been a real pleasure, everyone. Happy New Year. And I will see you all in a couple of weeks. We have a lot of exciting things. So make sure that you're just keeping up on all of our stuff here at Archer. And if you have any questions, you can always email us over here at advancedpractice@archerpulse.com. And make sure that you're doing your practice questions, 25 to 50 questions a day, and check out our Q bank. And if you need any additional assistance, Hiva and I would love to work with you in a tutoring session. So you can check out our availability, but always, all right. Thank you all so much, and have a wonderful day. And I don't know if you guys have got your planners yet for 2026, but I always say set some goals for yourself, both in a professional sense, a personal sense. What is it? Where do you want to go and end your 2026? It's a great North Star. So I always tell people, take a look, see where you're headed. And yes, I wish you all the very, very best as you move through, and good luck on board exams. Okay.